The hospitals that we build or that we rely on in the future will, of necessity, be smaller, because we cannot continue to treat the numbers of patients that we're going to have in the same way that we currently treat them. So absolutely, hospitals will have emergency departments, they will have post-operative facilities, they will have facilities for intensive care and high dependency. But chronic diseases are going to have to be treated in the community. And I mentioned this earlier this morning. We're going to have to rely more and become truly multidisciplinary in our approach to treatment of cancer patients. We're going to depend more on wearable devices, on sensors in the environment, and on telemedicine, where patients are monitored and under the surveillance of a medical practitioner or a medical team at all times, but without the burden of having to traipse to a hospital, to have tests done, to be constantly reminded that you're ill. Because that's not thriving, that's living with a ticking time bomb. And we need patients, if they have a chronic disease, to live in the community and to be able to have a quality of life. There are a number of advances and factors, I think, that are particularly relevant with regard to molecular diagnostics that are going to impact on the way we develop tools to monitor and to care for these patients that will have this chronic disease, cancer. And the first, I think, is around the area of detecting rare transcripts and single-cell analytics. We currently can do this, but we need to refine it, we need to make it more robust, and we need to make it safe. Safe, I mean, by not introducing bias or errors into the library prep that we do. We need to be able to decouple multiplexed signals accurately, reliably, so that they give us true information about the samples from the patients that we're looking at. When we look at single-cell analytics, we need to remember that those single cells are isolated from the parent tissue from which they came. And so we are eliminating, or we are not identifying, some of the crosstalk that happens between cells when we do this approach. One of the positives is, if we're looking at solid tumours, it does allow us to tease out the unique and exquisite signatures of individual cells and see how the sort of dynamic trajectory of some cells may evolve within a tumour setting. But the single cell analysis itself does, by necessity, eliminate those other signals from partner or neighbouring cells. Notwithstanding that, it is the bedrock of some of our liquid biopsy analyses. And in order to advance it, what I think we really need to do is not just depend on DNA profiling, but we need to increase the sensitivities of the technologies that we use so that we can simultaneously look at DNA, RNA, maybe correlate those genomic profiles with cell surface markers and use a multi-omics approach in order to identify single cells that are biologically relevant, as opposed to ones which are never going to affect a metastasis or a metastatic disease. And that's the second area I think really needs a lot more work and intensive research so that we can understand that process more. 90% of cancer patients who die because of metastatic disease, so it's effectively incurable when disease gets to that point. And we need to understand more accurately how this process works, how cells leave a primary tumour, what makes them do it, when they get into the vasculature, how do some cells survive? Because it's such a foreign territory for an epithelial cell, for example, to be in. And so some cells we know will enter the blood system as single cells, maybe as doublets or as microemboli. Some of the more aggressive cells we now know have the ability to cloak themselves with platelets and use that protective cloak in order to evade the immune system. And so we need to understand the metastatic process, because in doing that, we will identify new targets for therapy, new mechanisms or new ways that we can intervene and have therapeutic potential. It will also allow us to investigate the interplay more between the individual person, their age, whether their immune senescence may exacerbate the aggressiveness of a particular tumour. And all of this will be facilitated by liquid biopsy, as you've heard from earlier speakers this morning, not just in blood, but in other fluid samples also. And our ability to be able to utilize liquid biopsy and utilize it effectively at the different time points of a patient's pathway through their cancer, from diagnosis through treatment, through hopefully living with cancer as a chronic disease, needs to be developed. And we need to have a system that's adaptable so that we use the appropriate panels at the appropriate point in the person's course through their disease. As I've mentioned, we need to use multi-omics, so we need to not just look at DNA, but RNA, to look at exosomes and signaling between circulating tumour cells or between the fluid samples that we collect and the particles that are contained within them that will convey valuable information as to what's happening within an individual patient and as their disease progresses. And so there are a number of forces, really, I feel, that are shaping cancer care nowadays and moving forward over the next decade or so. First of all, we have to shift from a reactive stance that we currently have, waiting until somebody has something and then trying to deal with it. We need to develop more predictive healthcare, and NGS can help us do that. NGS in conjunction with some of the Internet of Things advances that are available now. So we need to tie in with telemedicine, with sensors that people can use in the community. We need to be able, if we're going to use liquid biopsy, and if we are trying to keep people in the community, to have systems where samples can be collected easily so that they're not impacting on a person's quality of life. It can be done without reminding them constantly that they are ill. And those samples then need to be preserved in a way that we can meaningfully analyse them in the lab. Whether that's at a local lab or a centralised lab is a moot point, but the ability to preserve those samples is imperative, and we need to work more in developing workflows that will ensure that the biological integrity of the samples is maintained intact. The other hugely important factor I believe that we need to understand and investigate more is the complex interplay between various factors that a person may have and their chronic disease, and in this case, cancer. And so I've mentioned already things like cardiovascular disease, diabetes, obesity, and our increasingly aging population all have a huge impact on the prognosis a patient may have, regardless of the mutation that may be driving their cancer. Previously, or most cancer research has looked at patients and just the type of cancer that they have. And we've got our epidemiological data from that. But that's not sufficient because people are different. Each one of us here in this audience, those of you watching online, each of you is an individual, and you have your own comorbidities or cofactors to bring to any disease that you might ever develop. And so we need to consider those. Clinical trials, for example, typically exclude people who are older and who have pre-existing chronic conditions. And yet we know that we are an aging society. By 2030, I think 70% of new cancers diagnosed will be in the older population. As things stand, 45% of men, 30% of women who reach the age of 65 will expect to develop cancer in their remaining lifetime. That's a significant cohort of patients, and it's one that we tend to underestimate in the mechanisms that we currently use. So we need to adapt our panels so that we take these factors into account. We need to incorporate features like their HLA type, maybe SNP profiles that will correlate with their ability to become resilient and handle treatment well, or those that don't, so that we can plan and manage their treatment regimens more accurately and more effectively. Another area where I believe NGS will play a huge role is in distilling this difference between survivorship and cure. Just because somebody has a mutation that has been identified does not necessarily mean that they need an active intervention. And so increasingly we become familiar with this idea of active surveillance or watchful waiting. Nowadays, none of us particularly likes waiting for anything unless we have a good reason. And so what NGS will allow us to do, if we manage and plan our panels effectively, is to bolster the confidence that the physician has in saying to a patient, you have a mutation, but your disease is likely to be indolent. If we monitor you, we will know when to intervene. And this is hugely important, A, because it gives reassurance to the patient that they can continue to live knowing that their disease is being monitored effectively. But there are other practical reasons, because there are toxicities that we create within the patient once we start a treatment regimen. There's the financial toxicity of some of the cost of some of the treatments that are available. And these need to be balanced against the well-being of the patient and their ability to live a fruitful life. And so it's hugely important, I think, that we adapt some of our panels so that we use them as adjuncts in that watchful waiting or active surveillance arena. And in this particular regard, I think the role of the liquid biopsy is going to be fundamental. And it's where we need to be able to have a system where we can have patients in the most minimally invasive way, have samples collected, and have them then processed in the most efficient, most sensitive manner that gives the most relevant information to the clinician. And if we do this, then what we are actually going to do is focus on well-being. I mentioned earlier there is a big difference between being alive and living, and we all know that. The WHO in 1946, when it published its convention, said that health is not the absence of disease. Health encompasses well-being, mental well-being, and an ability to flourish. And all of these things are important, and they're particularly important if you are the patient who has a diagnosis. It's not enough to say to them, you have a mutation, we have a drug. We need to be able to treat them so that they can live well. What we don't want to be able to do, or what we don't want to do, is to tell somebody, you've got this mutation, we'll treat it, you may develop resistance. There's no point handing somebody a ticking time bomb and then have them worry for the rest of their existence on what's going to happen. So we need to use our NGS so that we can reinforce the message that we are monitoring the system or the situation, and that we are facilitating people being well. Because if cancer research has to do anything, it's no longer about, having people survive, identifying things that will help us diagnose their disease. We have to focus on well-being, and that has to be the thing that drives us forward as we research and as we hopefully understand the mechanisms of disease and understand the factors that will contribute to a person's disease upstaging or in a person's ability to deal with the treatments that we give them.